Welcome back to the deep dive. Imagine this, just for a moment. You're a nursing student, maybe it's your first OB rotation. A patient comes in, she looks a bit uh, overwhelmed, right? And she's got all these questions about prenatal tests. Our mission today, it's to equip you to confidently guide her, through that whole journey. We're going on a deep dive into the absolutely vital world of assessing the fetus. We're aiming to cut through some of the complexity around prenatal screening, diagnostic tests. We'll unpack the why, the sort of underlying pathophysiology, the signs and symptoms you need to look for, and maybe most critically for your practice, the how. That means the specific nursing care, the interventions, and even key medications you'll definitely encounter. And joining me, as always, is our brilliant expert guide, ready to synthesize all this knowledge from our sources into practical, actionable insights.
It's great to be here. This is such a critical area, and it's a privilege to explore it. We've pulled from a really rich stack of medical texts today, trying to lay out the foundations of fetal assessment, but connect them directly to your role as a nurse.
Exactly. So let's roll up our sleeves, extract those essential nuggets of knowledge. This deep dive hopefully gives you a real shortcut to being well-informed about prenatal care. We've got some surprising facts, lots of practical insights for your nursing practice. Okay, so let's unpack this first. From a nursing perspective, why is all this testing, prenatal antepartum fetal testing, why is it so fundamental in modern obstetrics? What's the real driving force here?
Yeah, and it's fascinating how much things have changed, right? Historically, we were relying on, simpler methods, fundal height, basic fetal heart rate checks, things like that. But the core objective, that stays constant. We want to detect genetic disorders if they're there, identify any structural abnormalities, and really confirm the overall fetal well-being. From a nursing standpoint, it's all about being proactive, anticipating potential issues, catching them early, and intervening to dramatically improve outcomes for both the parent and the baby. It's about building that picture of health before birth.
Right. Getting ahead of the curve, spotting risks, giving families the best information possible. Okay. And that immediately brings us to a really important distinction for you as nursing students, screening versus diagnostic tests. What is the fundamental difference, and why is that distinction just so crucial when you're educating patients and managing their expectations?
This is foundational, absolutely. Think of it, think of it this way. Screening tests identify individuals at risk for a condition. They're like casting a wide net, right? Catching anyone who might need a closer look. Diagnostic tests, though, they confirm or rule out if someone actually has the condition. For nurses, explaining this difference is just paramount. Patients, they often hear a positive test and immediately think diagnosis, and that can cause immense anxiety. So we need to clarify that a positive screening test just means, okay, more investigation is needed. It's not the final answer yet.
That clarity must make such a difference for families. Okay, so let's dive into some key screening tests then. What should nursing students know about, say, the neutral translucency, the NT scan with the combined test? When is it done? What's it measuring?
Okay, the NT with the combined test. This happens early, specifically between 10 weeks and 13 weeks, 6 days of gestation. It uses ultrasound to measure a tiny fluid-filled space at the back of the fetal neck that's the neutral translucency. That measurement is then combined with results from specific maternal blood test serum markers. And the combined results help assess the risk again, risk for chromosomal abnormalities like trisomy 21, which is Down syndrome, trisomy 18, and also neural tube defects or NTDs. Those involve the brain and spinal cord. For nurses, understanding that increased fluid back there could indicate an underlying issue helps you explain why this measurement is significant. It's a physical clue.
Got it. So a specific anatomical feature plus blood markers. What about the multiple marker screens, like the triple and quad screens? When do those come in?
Right, those come a bit later, usually between 15 and 22 weeks. The triple screen checks 3 markers in the maternal blood: AFP, alpha-fetoprotein, unconjugated estriol, and beta-HCG. The quad screen, well, it just adds a 4th marker, inhibin A. Now, when the levels of these markers are either too high or too low, it can indicate an increased risk for trisomy 21, trisomy 18, and those NTDs again. From a pathophysiology view, think about AFP. Abnormal levels, especially high ones, can suggest an open neural tube defect because fetal protein leaks into the amniotic fluid and then crosses into the mom's bloodstream. So as nurses, explaining why these seemingly unrelated blood levels are important for fetal health is really key.
Okay, and then there's something called the integrated screen. That sounds like it pulls everything together.
It does, pretty much. The integrated screen has a couple of options, full and serum integrated. But essentially, it combines the first trimester screening data, so the NT and those early serum markers, with the second trimester markers from the quad screen. The first part is done between 10 weeks and 13 weeks plus 6 days, and the second part between 15 and 22 weeks. The real benefit here is by combining results from both trimesters, you get a single, more accurate overall risk assessment for trisomies 21, 18, and NTDs. And importantly, it significantly reduces the rate of false positives.
Fewer false positives. That's huge for reducing unnecessary anxiety.
Exactly. Less worry for families.
Okay, speaking of accuracy, cell-free DNA or cfDNA. This is much newer and people talk about how accurate it is. How does that actually work? What makes it so different?
Cell-free DNA, yeah, it's a really significant advancement. It's non-invasive, just a simple maternal blood draw, but it's highly accurate for certain conditions. What's kind of revolutionary is that fragments of the baby's DNA, actual bits of fetal genetic material, circulate in the mother's bloodstream. We can isolate and analyze these tiny fragments. It can be done pretty early, as soon as 9 weeks and 6 days, really any time up until delivery. And this test is incredibly effective at identifying risks for trisomies 21, 18, and 13. Also, certain sex chromosome issues, aneuploidies, and even some micro-deletions and duplications, which are tiny missing or extra bits of chromosomes. The real aha moment here for nurses is seeing how cfDNA has shifted the conversation. We often move from potentially needing invasive diagnostics right away to starting with this highly accurate screening. It reduces patient anxiety and the need for riskier follow-up unless it's truly indicated. It changes that initial counseling quite a bit.
That is a crucial shift in care. Okay, so after understanding all these different screening options, what's the main takeaway for nursing students when they're talking with their patients?
I think the main takeaway is that understanding these tests helps you counsel patients on what the results might mean. Is it negative, positive, or maybe even a confusing false positive or false negative? Your role is really to empathetically explain why diagnostic follow-up might be needed, manage their expectations, manage their fears. You're their knowledgeable, compassionate guide through this.
Okay. Now, let's shift gears slightly. This is where it gets really interesting, I think, for actually visualizing fetal health.
Yeah.
Ultrasound. How does it work fundamentally, and what are its broad applications here?
Ultrasound, yeah, it's amazing. It uses high-frequency sound waves. These waves travel through the body, and when they hit different structures like the fetus or the placenta, they bounce back, they echo. A computer then translates those echoes into real-time images, so it lets us non-invasively see the fetus, the placenta, the amniotic fluid, even the mother's pelvic organs. Its versatility is just incredible. We can assess size, growth, position, detailed anatomy, overall well-being. It really is like our eyes inside the body.
And we hear about different types, 2D, 3D, even 4D, but focusing on the timing, what are the key assessments we do in the different trimesters? And what's the nursing role in preparing for those?
Good question. In the first trimester, usually between 6 and 10 weeks, the main goals are confirming the pregnancy exists and that it's viable, meaning is there a heartbeat. We also precisely determine the gestational age using the crown rump length measurement that's most accurate early on. And we check for multiple fetuses, twins or more. We can also spot major structural abnormalities even this early. For nurses, this means explaining the procedure, maybe ensuring the patient has a full bladder, which helps get a better image sometimes, and just preparing them emotionally for potentially seeing that heartbeat for the very first time. It can be a big moment.
Definitely. And then as the pregnancy moves into the second and third trimesters, what are we looking for then?
Well, the second and third trimester ultrasounds allow for much more detailed fetal anatomy surveys. We look closely at the umbilical cord insertion, the placenta's location and health, and the amount of amniotic fluid that's crucial. These later ultrasounds are vital for monitoring fetal growth patterns over time, detecting structural issues that might only become apparent later, and also assessing for signs related to chromosomal abnormalities. We can even incorporate parts of the biophysical profile later on. From a nursing perspective, managing patient reactions is so important here. It's often their first real glimpse of their baby, which brings immense joy. But it can also be a source of significant anxiety if an abnormality is suspected or found. Providing emotional support, clearly explaining what they're seeing, what the findings mean, and what the next steps might be before, during, and after, that's a critical nursing role. You're helping interpret those images and their implications.
So we've talked about screening identifying risk. But what happens when those screenings do raise a red flag? That's when we move into the realm of definitive diagnostic tests. These give much more specific answers, but they often come with bigger implications for families. What does this shift from screening to diagnostic testing mean for nursing care?
It's a significant shift. We're moving from identifying risk to actually confirming or ruling out a diagnosis. And that has profound implications, right? For patient care, for counseling, for decision making. Nurses play an absolutely critical role here in preparing patients, both emotionally and physically, for these more invasive procedures. Because these tests, while generally safe, do carry a small but real risk. We often become their anchor during this time.
Let's start with one of those, chorionic villus sampling or CVS. What exactly is it? When is it typically done? And walk us through the nursing role.
Okay, CVS. This involves taking a tiny tissue sample from the chorionic villi, which are finger-like projections that make up part of the placenta. It's typically done early, between 10 and 13 weeks of gestation. The key is that this tissue has the same genetic makeup as the fetus, so it allows for direct analysis of chromosomes, metabolic conditions, specific genetic disorders. For nurses, your interventions are paramount. You'll provide really detailed pre-procedure education, make sure truly informed consent is obtained. You'll help with positioning the patient optimally, and then post-procedure, you're monitoring meticulously for any signs of vaginal bleeding or uterine contractions. You'll also instruct the patient on specific activity restrictions, usually for about 24-48 hours. And critically, you mentioned medications. Rhogam, which is Rh immune globulin, must be given to Rh-negative women after the procedure. This is non-negotiable.
Why is ROGAM so critical there?
It prevents Rh isoimmunization. If the mother is Rh negative and the baby is Rh positive, even a tiny amount of fetal blood mixing with hers during the procedure could cause her immune system to develop antibodies against the baby's red blood cells. Rhogam prevents that sensitization.
Got it. Essential safety step. And what are the potential risks involved with CVS?
While it's generally safe, there are risks to discuss. A low chance of spontaneous rupture of membranes, infection, and a very low risk of fetal loss. There's also a rare risk of limb reduction defects if it's done extremely early, which is why the timing is specific. Clear, calm discussion of these risks is vital.
Okay. Next up, amniocentesis. What is it, when is it done, and how does it differ from CVS?
Right, amniocentesis. This involves withdrawing a small sample of amniotic fluid directly from the amniotic sac surrounding the fetus using a needle guided by ultrasound. It's usually done a bit later than CVS, typically between 15 and 20 weeks, mostly for genetic analysis. We examine fetal cells that have been shed into the fluid for chromosomal or specific genetic studies. But amnio can also be done later in pregnancy, often in the third trimester, specifically to assess fetal lung maturity.
Ah, lung maturity. How does the fluid tell us about that? What's the pathophysiology?
Good question. For lung maturity, we analyze chemical markers in the fluid. The key ones are the lecithin to sphingomyelin ratio, or LS ratio. Lecithin and sphingomyelin are phospholipids, crucial components of lung surfactant, which prevents the air sacs from collapsing. As the lungs mature, the lecithin level rises relative to sphingomyelin. We also look for phosphatidylglycerol, or PG, another surfactant component that appears later in gestation. And we can do a lamellar body count. These are particles containing surfactant. So these markers directly reflect how developed the fetal lungs are, specifically their ability to produce surfactant. They tell us if the baby's lungs are likely ready for breathing outside the womb.
Fascinating. Okay, the essential nursing interventions for an amniocentesis still involves ROGAM.
Absolutely. Rhogam for Rh-negative women is still essential. Other key nursing interventions include comprehensive pre-procedure teaching, explaining the ultrasound guidance, what the patient might feel. You'll assist with positioning for comfort and access, meticulously monitor the fetal heart rate and any uterine activity both during and after the procedure. Afterwards, it's vital to assess for any signs of fluid leakage from the vagina or signs of infection like fever or chills. And a crucial nursing intervention is educating the patient on those warning signs to report immediately persistent cramping, fever, any fluid leakage.
And the risks associated with amniocentesis, similar to CVS.
Similar but slightly different profile given the timing and procedure. Risks are low, but include a slight chance of fetal loss, bleeding, infection, and premature rupture of membranes. Again, transparent communication and vigilant post-procedure monitoring are key nursing responsibilities.
Okay, so we've covered these really specific diagnostic tools. But our role as nurses doesn't stop there, does it? For many high-risk pregnancies, the real work involves ongoing, proactive assessment of fetal well-being. So let's turn to what nurses often do day to day or week to week to monitor that precious life inside. Why is this ongoing assessment so critical?
It's absolutely critical because this is where we proactively identify fetuses who might be at risk for adverse outcomes, especially fetal hypoxia, basically, a lack of oxygen. Early detection allows for timely intervention. We might need to deliver the baby early or take other steps to prevent serious complications like stillbirth or potential neurological damage. It's about watching for those subtle signs of fetal distress.
Let's start with the simplest, most accessible assessment, fetal movement counting, or kick counts. How do you actually instruct a patient to do this? What's considered normal and what's a red flag?
Kick counts are great because the patient can do them anywhere. We teach them to count distinct fetal movements daily, usually during a quiet time when the baby is typically active, maybe after a meal. A common guideline is to feel at least 10 distinct movements within a 1 to 2 hour period. But the key is consistency for that pregnancy. A significant decrease in fetal movement from the baby's usual pattern can be an early and sometimes critical sign of oxygen deprivation or fetal compromise. It's a key symptom suggesting potential distress. So, clear nursing instruction on when to call the provider if the count is low or if the pattern changes significantly, that is paramount. It can absolutely be a lifesaver.
Okay, moving to more technical assessments. The non-stress test, or NST. What exactly is it, and what does a reactive result really tell us about the baby's health physiologically?
The NST is a very common test. It monitors the fetal heart rate, the FHR, and looks for accelerations, increases in the heart rate that happen in response to fetal movement. We usually monitor for about 20 minutes. The underlying pathophysiology is quite elegant, really. A healthy, well-oxygenated fetus with an intact, functioning autonomic nervous system and central nervous system will show these FHR accelerations when it moves. It shows good neurological and cardiac function are linked. Basically, the baby's brain is telling its heart to speed up appropriately with activity. So a reactive NST is reassuring. It means we see 2 or more FHR accelerations of at least 15 beats per minute above the baseline, each lasting at least 15 seconds, all within that 20-minute window. It suggests a good prognosis, at least for the short term.
And what if it's non-reactive? What are the nursing interventions then?
A non-reactive NST is one that lacks those required accelerations. It doesn't automatically mean something is wrong, the baby could just be asleep, but it definitely warrants further investigation. Nursing interventions are key here. First, ensure proper patient positioning, usually semi-Fowler's or with a lateral tilt using a wedge to prevent supine hypertension, where the uterus compresses major blood vessels. That can affect fetal oxygenation. Sometimes we might use vibroacoustic stimulation. It's a device placed on the mother's abdomen that makes a sound and vibration. The idea is to sort of gently startle the baby awake and elicit movement and those FHR accelerations. For nurses, understanding this isn't just a trick. It's testing the integrity of the fetal nervous system's response. Does the baby react appropriately to a stimulus?
Okay, so if the NST is non-reactive, sometimes the next step is a contraction stress test, or a CST. When is it typically done, and how does it actually assess fetal well-being under stress?
Right. The CST is usually done if the NST is non-reactive, or if there are other clinical concerns about fetal compromise, especially worries about placental insufficiency, meaning the placenta isn't delivering enough oxygen and nutrients. The CST monitors the FHR response specifically during uterine contractions. The core idea, the pathophysiology, is that contractions naturally cause a temporary decrease in blood flow through the placenta and thus less oxygen transfer. A healthy fetus has enough reserve to tolerate this brief reduction just fine, but a compromised fetus, one already struggling with limited oxygen reserves, will show late FHR decelerations. These are drops in heart rate that start after the peak of the contraction and recover slowly. It indicates the baby isn't coping well with the stress. It assesses placental function under load.
How do you actually induce contractions for this test, and what are nurses specifically watching for?
There are two main ways. One is nipple stimulation. Having the patient gently stimulate her nipples can cause her body to naturally release oxytocin, which triggers contractions. The other way is a controlled intravenous infusion of synthetic oxytocin using an infusion pump for precise dosing. Nurses have to meticulously monitor both the fetal heart rate pattern and the uterine activity, the frequency and duration of contractions. We need to ensure there are enough contractions for a valid test, usually 3 contractions in 10 minutes, lasting 40-60 seconds each, but without causing uterine hyperstimulation, which could excessively stress the fetus. It's a careful balance.
And what are the key interpretations? Negative, positive?
Exactly. A negative CST is the desired result. It's reassuring. It means no late decelerations were seen with the contractions. The baby handled the stress well. A positive CST, however, is concerning. That means late decelerations occurred with 50% or more of the contractions. This indicates a high risk of fetal compromise during labor and requires immediate attention, often leading to decisions about delivery. There are also equivocal or suspicious results where maybe there are occasional late decelerations or other ambiguous findings. These mean the test isn't clearly positive or negative, and more monitoring or testing is definitely needed. Nurses are key in interpreting these patterns and communicating the implications.
Okay, let's talk about the biophysical profile, the BPP. This sounds pretty comprehensive. What are its 5 components? How is it scored? And what is it really telling us about the baby's condition?
The BPP is indeed comprehensive. It combines the non-stress test, NST results, with 4 specific observations made via ultrasound. So 5 components in total, they are the NST itself, fetal breathing movements, watching the chest move, gross body movements, limb or trunk movements, fetal tone, seeing flexion and extension like opening and closing a hand, and amniotic fluid volume, measuring the pockets of fluid. Each component gets a score of either 0 if absent or abnormal, or 2 points if present or normal. So the total possible score is 10. What it tells us is really about different aspects of central nervous system function and oxygenation. A score of 8 or 10 is generally considered reassuring. Low scores, especially 4 or less, are highly suggestive of potential fetal asphyxia, lack of oxygen. This often requires immediate action, which could very well mean delivery. For nurses, understanding that these components reflect the health of the fetal brain and its oxygen supply, essentially yes. The modified BPP, or MBPP, is a quicker screening tool. It combines just 2 components, the non-stress test and an assessment of amniotic fluid volume using ultrasound. It's often used for routine surveillance in high-risk pregnancies, when maybe a full BPP isn't needed right then, but a quick check of oxygenation via NST and long-term placental function via fluid volume is desired.
Okay, one more advanced technique. Fetal Doppler flow ultrasound. What can this specialized ultrasound tell us about fetal circulation and well-being, especially in those high-risk situations?
Doppler ultrasound is fascinating. It specifically assesses blood flow dynamics, how blood is moving in key fetal blood vessels. We often look at the umbilical artery, the middle cerebral artery in the fetal brain, and sometimes the ductus venusus. What's really telling is when we see abnormal flow patterns, for example, absent or even reversed end diastolic flow in the umbilical artery. That indicates increased resistance in the placental circulation. The blood isn't flowing easily from baby to placenta during the heart's relaxation phase. It's a clear sign of placental insufficiency. This can lead directly to fetal hypoxia. Doppler helps nurses understand the pathophysiology of fetal shunting, a protective mechanism where the fetus intelligently redistributes blood flow away from less critical areas and towards vital organs like the brain, heart, and adrenal glands when oxygen is getting limited. Think of it like the body's emergency power save mode. Recognizing signs of this shunting via Doppler tells us the fetus is already compensating, signaling a potentially urgent need for intervention before severe distress occurs.
Wow. This deep dive has certainly highlighted a lot of incredible technology and complex medical concepts. But thinking about our listeners, the nursing students, what is your essential role in all of this? How do you bring it all together for the patient?
That's such an important question. How do nurses bridge that gap between the high tech and the human experience? Because truly, nurses are undeniably at the forefront. We are crucial in patient education. Explaining these complex tests, the risks, the benefits, the implications, in a way that's understandable, clear, and compassionate, that's huge. We provide essential emotional support, helping patients and families navigate the anxiety, the uncertainty, the hope, the fear during what can be a really vulnerable time. We coordinate care, ensure that informed consent is truly understood, not just signed, and we serve as vital advocates for both the pregnant person and the fetus. And it goes beyond just monitoring. Nurses are the ones teaching the patient specific warning signs to watch for after a procedure, like how to tell the difference between normal post-amnio cramping and something more serious. Our ability to connect the data to the person, to provide that holistic, person-centered care, is just invaluable.
What a journey through fetal assessment today. We've really unpacked those crucial differences between screening and diagnostic tests, explored the incredible power of ultrasound, and gotten into the specifics of invasive procedures like CVS and amniocentesis, including those key nursing actions like administering ROGM. And we've really tried to understand the critical insights we gain from fetal well-being tests like the NST, the CST, the BPP, and Doppler flow, always linking back to the underlying physiology and potential signs of distress. I think the key takeaway for you, our nursing student listener, has to be that your role is absolutely central. It's not just about knowing the tests or the data points. It's about interpreting that information, communicating it compassionately, and providing the hands-on care and support that makes all the difference in these high-stakes situations.
Indeed. And maybe a thought to leave you with. As technology continues to advance, how will your role as a nurse evolve? How will you integrate these new tools while always prioritizing that holistic, person-centered care and addressing the profound emotional impact these assessments can have on families? What's one aspect of fetal assessment that you, the listener, find maybe most fascinating or perhaps most challenging after this deep dive? And how might thinking about that shape your future nursing practice?
That's a powerful thought to end on. We really encourage you to keep exploring these topics and think critically about your unique and vital role. Thank you so much for joining us on this deep dive into assessing the fetus. Stay curious, stay informed, and we'll catch you on the next deep dive.